My name is Dr. Eric Zhou. I am an assistant professor of psychiatry at Harvard Medical School and on staff at the Dana-Farber Cancer Institute here in Boston, Massachusetts. I have the privilege of chatting with you today about managing sleep after diagnosis. Now, in terms of our goals today, what I would love to be able to do is to give you an overview of what insomnia statistics look like in survivorship, some of the risks that come with having insomnia that is improperly or insufficiently treated, some of the risk factors for developing and maintaining the disorder, and then management options, which is the most exciting part because we get to talk about how to make your sleep better. Now, in terms of statistics in survivorship, I'm going to start with what is not insomnia. And this is because for many patients, we lump together all things related to sleep as just being bad. And it's really hard to be able to distinguish when there are other sleep issues that might be going on. Some common sleep disorders that are not insomnia, for example, could be something like obstructive sleep apnea. Now, obstructive sleep apnea is associated with the risk of insomnia, but these disorders are actually treated separately. So what is insomnia disorder? Well, here's a busy slide, and I really don't want you to get bogged down in the details. What I want you to concentrate on are some of the hallmark characteristics. So first, somebody has insomnia if they have difficulty falling asleep or staying asleep, or they wake up during the morning earlier than they want to. And it comes with it some daytime consequences. Something about the day is affected negatively because of the bad sleep. And this occurs at least 3 times a week for 3 months or more. And I underline the 3 months or more because for many individuals, they feel like their sleep has to be worse for longer in order to qualify for this diagnosis. But in fact, it is just 3 months and 3 times a week or more. And then the final characteristic is that this sleep disorder is not solely, and I underline solely because it's an important distinction. You see, there's a lot of things that can make our sleep more challenging, and oftentimes we try to chase that particular thing. Like maybe if we just manage the pain or we just manage our side effects of a treatment, the sleep disorder goes away. And in this case, what we know is that even though insomnia often overlaps with some of these other things like pain, depression, etc., even if you treated that other thing, the insomnia still lasts. So I encourage you to make sure that you think about this as, if I fully managed this other thing, do I really think that all of my sleep problems would go away? And for many, the answer would be no, which would mean we should work on it. Now, why do we focus on insomnia disorder among survivors? Well, the reason is because among all survivors, not just gynecologic, but among all survivors, insomnia is probably the most common sleep disorder that will be seen. In some studies, what we see is that in the general population, less than 1 in 10 adults have insomnia. But among cancer survivors, you're looking at maybe 1 in 4 or more who have insomnia. In one study that was conducted in 2011, what the researchers did was they followed a group of women post-surgery for 18 months. And what they found was among these cancer patients that insomnia is an incredibly common issue, not surprisingly, and that, as you might imagine, it's more common right after the surgery because of all the things that you may know all too well in terms of the short-term effects of just having had a surgery. But what I want to draw your attention to is that over time, the rates of insomnia do decline, but they don't fall off a cliff. It's not like it goes from 30-some% to 0. In fact, if you look over time, as I had mentioned earlier, about 1 in 4 people who are survivors still continue to struggle with insomnia. Now, this poor sleep can absolutely be triggered by the diagnosis and the treatment thereafter, as you see in this particular study. If you look at the middle, the biggest bar, These are patients who report that their sleep was disturbed at the diagnosis point. And to the right, you'll see that these are people who are reporting poor sleep happened in the 12, 24, 36 months, etc. afterwards. So as you might expect, the bulk of these patients have cancer as a major trigger point for their poor sleep. But importantly, a lot of people carry with them into their diagnosis that they are already poor sleepers and cancer just happens to make everything worse. Now, why is this such an important thing? Besides the fact that it's common, why do we have to, or should we think about this? Well, when we look at the science on sleep disruptions and health among cancer populations, we see that poor sleep is effectively interferes with things like our psychological well-being, meaning that it's associated with things like depression, it's associated with cognitive impairments, and it's associated with even immunological function. But I think one of the best studies that emphasizes how important sleep is for cancer patients was a study that was done a couple of years ago. This was among breast cancer. So not gynecologic cancer, but it was done among breast cancer patients. They took almost 100 of these patients who were between 36 and 80 years of age, and they gave them all a device called an actigraph. Now, an actigraph tracks your sleep objectively. This isn't asking patients how they slept, but it tells researchers how well these women were sleeping. And then they monitored them. What they found were that women who were good sleepers, and this is in the blue curve you see here, and these are women who were defined as good sleepers because they had a number called sleep efficiency, which we'll talk about later, above 85%. And then they followed these women over a 100-month period, and they found that the women who were good sleepers, measured using that actigraph, were more likely to survive. They were living longer than women who were poor sleepers. In fact, the findings were so stunning that they had this quote that I took out of their paper. Our data suggests that an improvement in sleep efficiency by 10% among women who were the poor sleepers could potentially lead to a 32% increase in survival time. This is astonishing to me to think that just good sleep can have such significant implications for health. And of course, they statistically controlled for things that might predict survival in this case. Now, risk factors for insomnia. This is an important thing to talk about because it'll inform how we treat this. This information comes from a model for the development and the persistence of insomnia called the 3P model. You'll see why, because you can see the 3 Ps at the top of your screen. So in terms of how insomnia develops, the first P are the predisposing factors for somebody to develop insomnia. What I want you to orient yourself to when you look at this chart is on the Y or the vertical axis, you see a sleep disturbance intensity score. This is just an arbitrary scale from 0 to 100, and we've drawn a line at about 50 to say, hey, if your bad sleep exceeds that threshold, you have insomnia. But if you're below, you might have some nights that are not so great, but you don't have insomnia. Again, just an arbitrary scale. But the message here is that if you look at somebody's predisposing factors, these are the things we bring to the table, things we can't change, like our sex, our age. These are all factors that make somebody more likely to have insomnia. But in and of itself, you see that these factors from baseline all the way through chronic, and this is along the bottom or the x-axis, it doesn't change. And baseline means that somebody, before they have insomnia, acute, early, and chronic refer to how long they've had insomnia. See that doesn't change. This is who we are, and nothing is different about this over time. But then if we look at the next element, which are the precipitating factors, These are things like being diagnosed with cancer, being hospitalized, receiving treatment for your cancer. All of these things are things that can kick your sleep into overdrive and get you over that threshold into insomnia. What's important here is if you look at this on the chart, over time, those precipitating or triggering things, they tend to fade away. If you think about, for example, the first couple of weeks after your diagnosis, it is incredibly life-changing. And it's very expected that your sleep disturbance goes up during this period. But for some of you who may be years post-diagnosis, while thinking back to that date can absolutely be very challenging, I would imagine that 5 years after your diagnosis, you don't feel the same level of intensity of emotions. And so what you see here is over time, that initial reason why you might struggle with sleep, it tends to diminish in terms of the intensity. So then why would your insomnia last? And that question relates to this idea of the perpetuating factors. So these are the last factors that go into this. And these would be things like what you do. And why it's important to think about these perpetuating factors is because they inform how we manage this disorder. So these would be things like your sleep effort, excessive time in bed, irregular sleep-wake schedules, daytime naps, etc. And we'll talk about how to manage some of these very shortly. So the takeaway here is that even though the factors that might have knocked you into the insomnia category initially fade over time, it's what we often do as a patient with insomnia that causes it to last. It's our actions, our thinking, and these are the things that we can change. Now, if you were to present to your oncology team and say, hey, doc, I'm really struggling with my sleep, it's likely that he or she will present you with a couple of options: pharmacotherapy or behavioral therapy. Now, I want to start with the medication option because that's one that is often given to patients as the frontline treatment. There was a really, really wonderful study published a couple of years ago where they looked at over 20,000 breast cancer survivors in a really large healthcare system where they were able to extract data through the medical records. And what they did was they looked at breast cancer survivors who had not taken a sleeping medication for 3 months prior to an appointment with their oncology team. And then they followed them for up to 7 years to see if they had any bone fractures. And this is an issue for a number of patients who are breast cancer survivors because of the fact that some of the treatments used to treat breast cancer affect bone health. And it's also a significant issue for an aging population as well. What they found were that this was the list of the medications they looked for. And of these patients, 4 out of 10 over the past 60 days had taken something for their sleep. The most commonly prescribed medications were lorazepam, trazodone, and temazepam. These may be drugs that you are familiar with and have heard of or might be taking yourself. And what they found in conclusion was that among these patients without any history of fractures, prescription sleep aid medication was associated with a significant 33% increased risk of fractures, even after they accounted for something called bisphosphonate, which is a medication used in breast cancer patients to preserve bone health. Meaning there are consequences associated with medication use for sleep that go beyond just the things we normally think about, like dependence on the medication or, say, the side effects, like the next day we feel a little bit woozy or hungover. Now, I also want to mention melatonin is commonly used as a treatment nowadays. In a literature search that was done a couple of years ago, they looked at the use of melatonin among cancer patients and survivors. What they found were that there were only 5 randomized controlled trials that were conducted. And why they picked on RCTs or randomized controlled trials is because these are the gold standard trials to be able to prove whether or not something is more effective than a placebo, for example. In their review of the literature, what they found was that 2 of those 5 trials had no significant improvement on sleep quality for the use of melatonin, which really means the literature in this field is very, very mixed in terms of whether or not it can be beneficial. Now, I do wish to note at this moment that there are true and very real placebo effects to taking something for your sleep. And so my argument to patients is if you are taking melatonin and you've informed your oncology team about this and they don't have concerns about it and it's working for you, then certainly, absolutely, you should continue to take it in order to help you sleep. However, this is something that is commonplace because melatonin in the United States is not an FDA regulated product, which means that there is no oversight into making sure that what that bottle says they're selling you is actually what's contained in that bottle. In a study that was published just a couple of years ago, what researchers did was they went out and took multiple over-the-counter supplements for melatonin. They analyzed them. What they found was that one of their 25 samples didn't contain any melatonin, but actually contained CBD. And in the products that contain melatonin, the actual quantity of melatonin in that bottle varied greatly from less than what was supposed to be to much, much more than that labeled quantity. And that the vast majority were inaccurately labeled. So it's important that if you're talking about getting this substance, that you try to make sure that this is something that is in some way reviewed or has some oversight to make sure that you are getting what you are purchasing. Another common treatment path that is used nowadays is cannabis. The Multinational Association of Supportive Care in Cancer published a statement about this, where their conclusion was, given the lack of studies on insomnia as a primary outcome among cancer patients, there simply isn't enough high-quality evidence to recommend the use of cannabis as a first-line treatment. And that there is, in non-cancer patients, not a lot of compelling research to show that it is always and consistently effective at improving sleep. They discourage the use of cannabis as the first frontline thing that we try when it comes to insomnia. Now, you might be asking then, what is recommended as the frontline treatment? So the National Comprehensive Cancer Network publishes guidelines for how to help patients. In their survivorship care guidelines, they state in terms of a treatment option that the preferred treatment is something called cognitive behavioral therapy for insomnia, or CBTI. And there are significant impacts of this. Like, for example, a very recently published paper showed that not only does this improve somebody's sleep, but it can absolutely improve things like cognitive function, which is a common challenge for a number of cancer survivors. Now, what exactly is CBT for insomnia? Well, the first and perhaps most important element is something called sleep restriction. What this describes is limiting somebody's sleep opportunity, meaning the time that they spend in bed, to an approximate sleep need on average. One of the challenges is people who are poor sleepers often spend more time in bed in order to try to get more sleep because they haven't gotten good sleep in the past. But by doing so, they actually fragment or interrupt their sleep because their body doesn't need 9, 10, 11 hours of sleep. They need less. And as a result, if they're in bed for 10 hours and they only need 7 hours of sleep, on average, they may be awake at the beginning, middle, or the end of the night for a couple of hours. So the goal of sleep restriction is to consolidate somebody's sleep so that it is less fragmented and that this sleep occurs at around the same time every day for a consistent period of time each day. The the last two things I want to flesh out a little bit here, which is the occurs at a consistent time of day, meaning a good sleeper who say needs 7 hours of sleep might sleep between midnight and 7 a.m. every day. A poor sleeper sometimes sleeps from 10 till 12, is awake for an hour, sleeps from 1 until 4, is awake for an hour, and they might sleep from 5 until 9. That is not a good pattern. And then for a consistent period of time each day is a duration piece. Good sleepers sleep about the same number of hours every single night. Poor sleepers, on the other hand, sometimes might sleep for 5 hours and sometimes might sleep for 10 hours to make up for the days in which they got 5. And that roller coaster pattern, which is very typical of insomnia patients, is one that we want you to steer away from, because even though the average of 5 and 10 is 7.5, which means over the course of a couple of days, the average is in that sweet spot. Because it's this inconsistent dosing, it is a challenge. The next piece of CBTI is something called stimulus control. The basic principle is that you use your bed only for sleep. And the goal here is to remove a conditioned response of being awake in bed. What I mean by that is, if you remember learning in high school about a scientist named Pavlov and his dogs, you might remember that he would ring a bell and feed his dogs at the same time. And eventually what happened over time was, if you just rang the bell, the dogs would salivate because they expected or paired the bell with food. In this case, if you spend a lot of time not sleeping in bed, you actually train your body not to sleep in bed, or at the very least, confuse it in terms of whether it should sleep or be awake. Now, here is where I hear patients talk a lot about things like using their phone or watching TV in bed. And while those are not great activities, the most problematic activity for somebody with insomnia is what's called sleep effort. This is where a patient tries very hard to sleep when they go to bed. And it's an understandable experience. You're struggling with sleep. You haven't slept well for days, and all you want to do is to fall asleep because you might have to get up early tomorrow for a meeting or to take the kids to school. And by putting that pressure on yourself to try to sleep, not only do you condition that bed as a place for not sleeping, but that pressure creates performance anxiety, and it becomes even less likely that you will be able to fall asleep or fall back to sleep, which then reinforces that worry. So that's something we want you to avoid. In terms of what you can do, I encourage patients to get out of bed and to do activities that they feel like they enjoy. I don't mean necessarily going out for a run at 2 o'clock in the morning, but it could be something like even watching a television show downstairs on a couch that you enjoy, that maybe your spouse won't watch with you in the evening. Now, be sure that you don't fall asleep on the couch, because if you do, you start to train yourself to then sleep on the couch. The next element is sleep hygiene. These describe tips or tricks that you've probably tried before when you're seeking help for your insomnia. And they include strategies like reducing electronics use in the evening, avoiding caffeine and alcohol use before bed, and increasing physical activity. Now, it's important to underscore that if you only implement clean sleep hygiene, that it's unlikely that if you have insomnia, it will cure the disorder. But it's a helpful complement to these other things that we've talked about. And it's something that I think we should all consider in terms of helping improve our sleep. The fourth element is something that is called cognitive therapy, which includes setting appropriate expectations for sleep duration and its impact on next day function. Now, sleep duration is something that we hear a lot about because people want to get more sleep. And I tell patients that the goal is actually not to get more sleep, but to get the right amount of sleep. That's good quality sleep. And the right amount of sleep varies from person to person. For adults, it's typically between 7 and 9 hours per night. But there are also a significant number of adults who need 6 hours of sleep or 10 hours of sleep. It doesn't make them any worse in terms of their sleep, how they function. We're just all different. And so in this case, it's important to understand that you are not an average, meaning you don't need to get 8 hours just because that's the average amount of sleep an adult needs. You have to figure out what your number is. Now, this idea that we put a lot of pressure to sleep well for some patients is something that I had alluded to and described a little bit earlier. But in this case, it is at the heart of, for many of my patients, the biggest reason why they feel like they cannot successfully do some of the work that's necessary for their sleep. A part of the beginning of CBT for insomnia requires that patients get a little bit less sleep because they're not allowed to sleep in on the weekends, for example. And as a result, they feel pressure to have to fall asleep sooner the next night. And as part of the treatment, the goal is to help patients understand that they've likely in the past gone through periods where they have not slept very well and they've still functioned just fine. Might have been a little bit harder, might have required a little extra caffeine. They still got through their day. And in our case, that short period of discomfort is building towards a better sleep pattern overall. And finally, relaxation therapy is typically part of CBTI. There is no right activity for this, meaning whatever you do to reduce your body's arousal level is the right activity if it's something that you like. I encourage you to engage in this activity consistently if possible, meaning if you can do something like deep breathing every single day, that would be a wonderful thing. But the goal is to reduce the overall level of your arousal, not to magically initiate sleep. I see patients who do this a lot where they might say, do a meditation exercise right before bed, hoping that that knocks them out. Well, conversely, it might actually awaken them because they're doing this thing, trying to sleep. And if you remember what I had mentioned earlier, sleep pressure is the bane of good sleep. So absolutely do this. You can absolutely do it in the evening, but don't do it right before bed, hoping and praying that that's the magic pill to knock you out. Now, here's an example of what you might see with regards to somebody's sleep. This is a sleep diary, which patients fill out in order to track their sleep patterns over time. You write down the amount of time you take to fall asleep, the amount of time you're awake, the time you wake up, etc. And what we do in clinic is we look at these numbers and we calculate somebody's sleep efficiency. So we add up the amount of time that patients spend asleep, usually over the course of about a week to 2 weeks. Then we divide that by the amount of time that they spend in bed. We multiply that by 100. And if you remember from an earlier slide where we talked about the importance of good sleep and the implications for a group of breast cancer patients, 85%, I hope you remember, is the number that I had mentioned, is usually the cutoff, which means we don't expect that for all sleepers. You go to bed, you immediately fall asleep, and you stay asleep until your alarm in the morning. It's usually not possible. But if you spend about 85, 90+% of your night sleeping, compared to the amount of time you spend in bed, that's actually a pretty good ratio. So in this patient's case, they spent 8 hours and a little bit more in bed, but they were only sleeping 6 hours of that time. That gives them a sleep efficiency of 74%. And they told us that they needed to be out of bed 5 o'clock for work. So how do we implement this treatment? So we set their out of bed time first based on their schedule, and we limit the amount of time they spend in bed to the average sleep that they had been getting over the past couple of weeks, plus a 30-minute window, because as I mentioned, we don't expect you to immediately fall asleep once you go to bed. You usually have a 5-hour minimum for this because in part, worse sleepers tend to overestimate how long they're awake in the middle of the night. And if you do, I don't want to shortchange you and get you to a point where you really are sleep deprived beyond what the real amount of sleep is that you're getting. And the store hours for bedtime and out of bed time mean this. So for this patient, their prescription is an 11 to 5 schedule because, as I mentioned, they had to get up at 5 a.m. in order to make it work on time. And what we do is they were sleeping about 6 hours and we add an extra half hour in there. And 11 p.m. is the time that they are allowed to go in bed, but not necessarily have to go to bed. 5 a.m. is the time that they have to get out of bed, no matter what happens. So think about the beginning like when a store opens. You don't have to go when the store opens. And at the end, you have to leave the store when it closes. In terms of what this might look like for patients, over the first couple of weeks, you see a significant decrease in the amount of time it takes to fall asleep. In this case, your sleep onset latency. This is because you are spending less time in bed and you are likely, or more likely, I should say, to be going to bed when you are actually ready to fall asleep rather than when you go to bed hoping to sleep. You also see a significant decrease in the amount of time that you spend awake in the middle of the night after you've already fallen asleep. Now, here's an intriguing chart because what you see here is the time in bed in blue versus the total sleep time in orange over the first 5 weeks of a typical patient's response to treatment. What you see is actually, if you notice in the orange, the amount of sleep they get at the beginning actually decreases when we implement stimulus, control, and sleep restriction. Remember, that's expected because we're forcibly limiting the amount of time that somebody stays in bed. But then that likely rebounds or increases as their sleep becomes more consolidated or efficient in the coming weeks. And so you actually see this really nice triangle shape that comes out if you were to chart this as we, over the course of about 5 weeks, implement things like sleep hygiene, cognitive treatment, and relaxation exercises. Now, if this is something that you're interested in, these two manuscripts that we've published are much more academic. And if that's the kind of patient you are, I encourage you to look them both up. They are available without having to pay any sort of a fee to a journal. And I would encourage you to consider reading this as our argument for why your cancer center should be thinking about sleep, and also things that we've done to adapt CBT for insomnia for cancer patients. If you are less academic, there are many good books that you can publish or purchase anywhere that a publisher sells their books in terms of cognitive behavioral therapy for insomnia. I would argue many of them contain the same kind of information. So whichever one you seem most interested in is probably the right one for you. If you would struggle with just reading a book and being able to implement strategies, then I encourage you to go to the Society of Behavioral Medicine's website. They will provide a directory of clinicians who can offer this treatment by state or province for you to be able to find somebody locally. And since the COVID pandemic, there are increasing numbers of providers who will provide this work via telemedicine, so you can hopefully find somebody within your state without having to drive, if that is something that is a barrier for you. Now, with all of that said, this is my email address, and I encourage you to reach out if you have specific questions that you are struggling to navigate as you go through this experience. I promise you that sleep is something that we know how to improve. We may not be able to make it perfect, but we can absolutely make it better for you in the circumstances that you are in now. Thank you so much for your time and attention.